Next, we'll get Dr. Shenise Gilyard. She is an assistant clinical professor in radiological science at UCLA. She did her medical school at Case Western Reserve University School of Medicine, did her residency at Emory University in DR, and her fellowship at UCLA in VIR. And her clinical focus is sickle cell disease, post-transplant interventions, as well as trauma.
All right. Hi, everyone. I'm Shenise Gilyard. I'm an interventional radiology attending at UCLA. We're going to take like 5 to 10 minutes just to chat about sickle cell disease, which is kind of strange for an interventional radiologist to be talking about, but I think it is a great thing for us to kind of think about because these patients are everywhere. Like I said, I'm Shenise Gilyard. I'm an assistant professor of interventional radiology at UCLA. And the first question I'm going to ask is, why sickle cell? So the reason that we're talking about sickle cell is that the life expectancy nationally is 56 years, which is already unacceptable. But in the California area, it's only 42 years. And the cause of death for a lot of these patients is acute chest pain or acute chest crisis, and it accounts for about 30% of mortality in sickle cell disease, but it still isn't the full picture. And then when we break down acute chest, just check the chat. Okay. I'm so sorry. The precipitating factor is still unknown in up to 50% of cases. So even though this is a well fleshed out disease in the hematology literature, it's not well understood in IR. So this kind of looks at two similarly known genetic based diseases, both sickle cell disease as well as cystic fibrosis. And it kind of compares and contrasts the research progress in these diseases. And so for a long time, there was some NIH funding in sickle cell, but a lot of the mainstay of treatment for the past 30 so odd years has been hydrea, which increases your fetal hemoglobin and overall does reduce the number of sickle cell crises one may have. Now we have the breakthrough of CRISPR-Cas9, and we are fortunate that this is occurring. However, the cost of CRISPR is going to be over $1 million per patient, and every patient isn't going to be a candidate. So we're still fleshing that out. And so like kind of the future gene editing and such like that, even though it showed promise in the trial where there were 9 patients, they were very, 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 very well selected. So this isn't going to be something that I think is going to be broadly available to our patients that are suffering. And so why are radiologists, or an interventional radiologist most specifically, there are about 100,000 patients in the United States that live with sickle cell disease. And of these patients, 57% of these patients will have at least one emergency room visit. So most kids, by the time they get to 18, have had 27 imaging studies by the time that they turn 18. So even if you don't think you see these patients, you see them if you're practicing radiology in the United States of America. So kind of thing is, if not now, if when, and then if not me, who? So at UCLA Health, we're trying to build a center of excellence for to improve the life expectancy of these patients. And so at UCLA, before I arrived, I kind of looked at the diagnostic imaging in sickle cell disease. We've done some imaging for stroke, which is either, cross-sectional imaging or transcranial Dopplers. A lot of studies, not a lot, but relatively small number compared to all of the studies, but the large majority of studies in our sickle cell patients were for acute chest syndrome and PE. And then sometimes osseous infarction or infection was another part of the study. So initially, before arriving, I looked at, the encounters, and we only really had like 50 separate patient encounters in the IR department, none for pain, none for hepatobiliary, which seems kind of strange because sickle cell disease is a multi-systemic disease, and pain is something that IRs treat in every other disease, but we don't necessarily treat it in sickle cell disease. And so we also estimate that we're not seeing all of the patients that have sickle cell disease in LA County. And so I'm just going to admit this person. There are about 2,500 adults in LA County, we think, with sickle cell disease, and most of them don't have primary care or a hematologist. So sadly, a lot of the patients that we see are coming in and accessing the emergency room in crises, and they're not being well managed overall. So my role now is to kind of help streamline the process. And so I'm one of the few interventional radiologists in the country, I think, that is part of a primary sickle cell team. There's some places that have sickle cell centers of excellence that do have a radiologist, oftentimes is diagnostic, but everyone doesn't always have IR. But one of the biggest things that we can do is streamline vascular access for patients with sickle cell, build pathways for care optimization for these patients, as well as like look at targeted interventions to reduce their pain, and then, you know, using our skill set, which is image guidance. So on this image, I'm just kind of pointing out access, and we have a dual lumen vortex port. So the reason I'm bringing this up is, even though access isn't the most exciting part of some of our jobs, it's like one of the most crucial points for sickle cell patients. So most severe sickle cell patients will eventually have access issues by the time they reach adulthood. So what's something that's demonstrative of this fact is the fact that here's a case. So I have a 51-year-old woman with a history of multiple DVTs, PEs, had IVC placement, filter placement, multiple ports that have been exposed or removed for various issues, and then she has severe sickle cell disease and strokes. She needs an exchange transfusion, which is also a mainstay of really severe care, but she's having difficulty with placing femoral catheters. And so someone placed a catheter. We weren't entirely sure where it was, but it essentially just terminated in nothing. And this is a CT that basically shows that she has essentially collateral only in her chest and no actual central veins to work with. So we hopefully would like to be involved before then. And then this is her high VC filter. This is not this patient, but the plan for this patient is essentially having to do IVC or SVC reconstruction, probably IVC reconstruction, and then place a dual lumen vortex port for this patient for access. So that's a kind of a long, difficult case that, you know, we can do, and I'm glad we're going to be doing this for this patient, but it's also a big issue, like that the patient even got that far. The other thing that I've talked to my hematologist about is ferriheme. So it's a relatively new kind of way to image, but it creates beautiful blood vessel imaging. So in my practice, I've moved towards a lot of, for my complex like reconstructions and understanding the anatomy of patients, I use CTA sometimes, but if I can get them a ferriheme study, I do. And then we just reduce the amount based on if they're iron overloaded or something like that, because sometimes these patients get a lot of transfusions, they have iron overload, so we don't want to exacerbate the problem. So ferriheme is basically just iron, and it gives you gorgeous contrast in the vessels without the effects of radiation. Let me just check the chat. Okay. All right. So like I said, this is work, and warning, it's a high risk procedure. Someone in the chat kind of mentioned, you know, it's, yep. Yeah, Dr. B just said, yeah, sharp recan on a sickle cell patient. Yeah, they were very grateful. And yeah, we're right now at UCLA working. We've been doing a lot with Dr. Finn and a lot of the colleagues here at optimizing our ferriheme protocol. And I'm blown away. I love the 3D recons. Our 3D recons on our MRIs are so much better than our CTs. And so just a little knowledge for our trainees is, though the dual lumen, it is a lot bigger port. I'm pretty strict about my ports. And they're 11 French, they're bigger, they're heavy. So they need about 3 weeks to heal. So sometimes like I had to do a really like complicated port revision one time where someone left the IR with a port accessed, and then it never healed properly, and they developed a huge hematoma. And then I was just had to evacuate a bunch of clot that area out and redo it. And then whereas our regular ports are about 8 French. So just one quick point, because I know we're running out of time, is the future for these patients, in addition to standardizing their vascular access, et cetera, is pain interventions. So one of the things that I've been doing in the acute phase is when patients come into the hospital is hip injections in the acute phase. Sometimes patients have avascular necrosis. So it's really important to do this with no steroids, but also some nerve blocks. So we're getting into femoral nerve blocks, pericapsular nerve blocks, and then genicular artery embolization is a small thing that we can do for pain. Sometimes patients have pain that is related to sickle cell, sometimes it's not. Although it's something I haven't yet done in my sickle cell patients, just because I'm still worried about avascular necrosis and exacerbating a pain crisis. So I tend to try to stay away from embolizations and just do nerve blocks and then also doing intercostal nerve blocks And for that, you can use a steroid because it's more rapidly metabolized. So it's kind of a field that I'm kind of trying to find my way and trying to standardize the care for this patient for both on the diagnostic and interventional side. But I think it is like a way to think about IR instead of being like procedure specific, but really disease specific and looking at the entire spectrum of disease. And with that, I think we're at time. So I just wanted to thank everyone for their time. And then this is a saying I always say is many hands make the work light. So there are a lot of societies and oftentimes we're super siloed, but if we understand the disease process that we're treating, we can work together and improve the lives of these patients. So thank you very much.
It's a great talk. Oh, we do have time for one or two questions. One or two. Dr. Huntsman.
Yeah, we have some questions in the chat. So for hip injections, are you doing 2 nerve blocks? And then what is your pericapsular block technique?
Okay, so that's a super great question. And I actually for the hip injections, I actually do kind of what MSK is doing. So sometimes like it depends on the patient. So I have one particular patient that when they're when they come in, they have they have imaging findings only on MR of osteonecrosis of the femoral head. So I kind of do essentially what we do for like the acute. So I use a long acting, I usually use ropivacaine. And I've started injecting ropivacaine in the patients, and like once they do that, and they also are getting their standard protocol for the sickle cell team, they've been able to improve their like kind of more rapid recovery, because basically it's taking their pain from a 20 out of 10 down to at least like 8 or so, and then they're able to catch up and kind of get out of the hospital in a more timely fashion. And then for our pericapsular technique, I actually partner with our anesthesiology colleagues, and sometimes they'll do the pericapsular for us, just because we have so many hospitals. Sometimes I haven't been able to get there, so I actually haven't done all that many in the inpatient side yet, because we're just in the process of building the program. But once we get it kind of operationalized, I think we'll probably take over that service line as well. And then I have one more question. How do you build up the patient relationships for follow-up? So that's basically through heme is going to be your kind of the key to maintaining the relationships. And I'm on the sickle cell group. And so what we do is we basically, for our sickle cell group, we do provider check-in on a monthly basis. So patients that are having really severe pain issues or access issues, we bring them up at our monthly sickle cell provider check-in so that they can be on our radar, and we can make sure that kind of like they're discussed in a multidisciplinary fashion, no different than our cancer patients.